we're going to go ahead and get going with our speakers. Our discipline group will address the challenges of respiratory care for people with cystic fibrosis and other comorbidities or pregnancy. Participants will hear the perspectives of care team members as well as with people with cystic fibrosis and other comorbidities. Dawn is going to go ahead and stand up and introduce our first speaker.
Good morning, everybody. I'm Dawn Selhorst. I'm the co-moderator of this session. I'm from Nemours Children's Hospital in Wilmington, Delaware. And I want to say thank you for getting up so early to come to our session. Hopefully you get a lot out of it. And who all went to the Jeopardy session yesterday morning? Amazing. How fun was that? Right? We saw how competitive PTs and RTs can be. Some housekeeping stuff. Just remember, by now we all know that if you have a question that you can post it in the app, or we have one microphone here that you can come up to at the end of each of the talks to ask a question. And I'd like to introduce Dr. Lauren Greenwald. She is the CF Associate Director, Center Director at our hospital, Nemours Children's Hospital in Wilmington, Delaware. She attended medical school at the Philadelphia College of Osteopathic Medicine, completed her residency at Lehigh Valley Riley Children's Hospital in Allentown, Pennsylvania, and completed her pulmonary fellowship at Nemours Children's Hospital in Delaware. After her fellowship, she returned to Lehigh Valley and spent time as the CF Associate Director. She focused on improving the sweat chloride testing process and restructuring a multidisciplinary CF clinic. After returning to Nemours Children's Hospital in the past year, she assumed a larger role in the research and program development related to newborn screening and sweat chloride testing and its implications for our infants and families overall. CF is the reason that she chose to become a pediatric pulmonologist. She loves working with the CF families and watching our CF children grow into amazing adults. Since her fellowship, she has focused on CFTR modulator therapies and their real-world implications, primarily related to respiratory, infectious, and nutritional outcomes. Through this research, she has had the opportunity to collaborate with colleagues nationwide and learn the practices of other CF physicians, which have enhanced her practice and patient care. So I'd like to introduce Dr. Lauren Greenwald, and we're so proud to have her.
Thank you, Dawn, and thank you guys for having me today. It's a pleasure to speak. I will be discussing a CF patient who has demonstrated both medical and social complexity, which have all directly impacted his care over several years. I have no disclosures related to this presentation. So my objectives are to review a case of multiple respiratory infections, primarily ABPA and NTM, in a CF patient, to address the added complexity of low socioeconomic status with acute and chronic illness, and to further address the role of pediatric to adult transition in impacting care. And I have a feeling that many of our centers have patients just like this who just affect our everyday. So the case is a 17-year-old Black male with cystic fibrosis with the identified mutations listed here. He's pancreatic insufficient with moderate persistent asthma and impaired glucose tolerance. He came to CF clinic with increased coughing, wheezing, shortness of breath, and chest pain. It was about 3 to 4 weeks after I returned as an attending, and so it was kind of jumping in 2 feet. He reported symptoms for the past 2 to 3 weeks, but he had been admitted about 6 weeks prior with similar symptoms and felt that they never fully resolved when he went home. He had a persistent cough day and nights. He had coughing fits where he would get very dizzy, lightheaded, and reported at one time he did pass out, which prompted his evaluation. He produced thick green to brown colored sputum, which was new for him, that had improved on his previous admission. He has frequent diarrhea with urgency and did report that he ran out of enzymes 2 weeks prior coming to clinic, and he did not have any of his supplements at home. He did not report any systemic symptoms of fever or URI symptoms suggesting an acute infection and had presented with these symptoms in the past. Just of note, he did report adherence to elexacaftor, tezacaftor, and ivacaftor, saying he took it twice a day. He said he started taking his airway clearance again, which he had stopped once he was discharged from the hospital, and was doing at least once a day treatments. He did endorse, he also uses Symbicort to manage asthma daily. He does endorse frequent marijuana use and vaping, but did not have any other sick contacts, which we did ask. Highlighted in red are just pertinent positives on his physical exam. So his saturations were normal, which was reassuring, but he did appear fatigued. He had diffuse inspiratory and expiratory wheezing, diminished aeration in all lung fields, at least posteriorly, and scattered crackles, and had chronic findings of clubbing. His growth was fine, actually. So the inferior star there is where he started at the end of his hospitalization, and the superior star is actually showing that his BMI improved while he was outpatient, so we didn't have any nutritional concerns at this time. His spirometry at this visit, so just to preface too for all of our respiratory therapists, for some reason every time he does trials of spirometry, the more attempts that he produces, the worse his efforts become and the worse his numbers are. And so he was not able to do many attempts, but we did get at least a few that we could interpret and that were reproducible. There was significant airway obstruction noted on spirometry, as you can see. His baseline FEV1 was 98% when he left the hospital, so there was significant decline, showing a 60% here. His small airways were also 49% when he left the hospital not that long ago, and now are showing at 25.7%. He was unable to perform post-bronchodilator assessments because his coughing increased and his efforts reduced on each subsequent trial, so we did not check for bronchodilator responsiveness. So at this time, because his symptoms, while significant, were manageable at home, and he had not really optimized his outpatient therapies, we decided to perform initial outpatient therapeutic planning. So we did 5 days of oral corticosteroids. He's very responsive from an asthmatic perspective and had wheezing on exam. We did oral antibiotics. We used ciprofloxacin this time. He typically grows MRSA. He's grown MRSA since he was an infant, but in the past year had grown Pseudomonas twice with significant growth, so we wanted to expand coverage. We obtained a new sputum culture that day, which actually did not grow any bacteria within the next 48 hours. We ordered a chest x-ray that he did not obtain. He had received a ride from a relative that day and felt that he could not stay and wait. We recommended follow-up within the next 4 weeks. Trying to bring him back too soon causes increased anxiety, so we did say 4 weeks to follow up, but call us if you need us. So we did not get any updates in the next week or so. I heard nothing. We all check in when we have huddle every week. Did anyone hear from him? Nothing. But he has a fantastic relationship with our wonderful social worker and reached out to her 2 weeks later, reporting increased chest pain, shortness of breath, persistent coughing, and reduced appetite, which I think is comical, but also probably very common in centers that nobody called me. They called our social worker, or sometimes they even call our respiratory therapist to say, we don't feel well, what do we do? And so we offered a same-day appointment in clinic, but he reported he didn't have transportation. We offered a next-day appointment, which he agreed to, and gave him parameters to present to the ER, so what to look out for, that he would need to be evaluated emergently. We also updated our inpatient pulmonary team, just in case he did arrive, which he does oftentimes in the ER, and our ER physicians call for help in the after hours. He came to the ER that day. A few hours later, he presented, and oh, by the way, now he's 18. Which adds a level of complexity, at least in our pediatric clinics, that sometimes we aren't prepared for, especially depending on the patient. So our fabulous social worker met him in the ER and helped him to register at the front desk. She helped update his contact information, sign consents for treatment, provide support during his evaluation and his plan for admission because he did present alone. However, due to ongoing symptoms and failed outpatient therapy, we decided to admit him to the pulmonary service for inpatient hospitalization. His baseline evaluation on presentation showed essentially still stable, no hypoxemia. He was coughing throughout his exam, but his wheezing had improved with steroid use. He's very good at using pills, but not great at chronic therapies, right? So acute management, he understands the benefits. Long-term management, much more challenging. He had crackles and rhonchi in all lung fields, but the left side seemed to be worse this time, which is different for him. They did get an x-ray in the ER as well, and so we can talk about the plan as kind of it comes up. But we discussed at that time to just admit him for IV antibiotic therapy, airway clearance, hydration because he seemed a little bit dehydrated, I think just clinically, and then further workup. So we got a chest x-ray here that you can see on the right. Of note, there is opacity in the right middle lobe. Does the arrow work? No. Okay. So the right middle lobe shows an opacity as well as the left lower lobe. As you can see, some streaking and atelectasis there, and he has significant right upper lobe opacification as well. That's it's kind of improved on this imaging compared to others, but he was also noted to have nodular densities more central in the chest. His viral panel was negative. And his sputum culture grew MRSA as it normally does. However, this was the first time he grew Aspergillus. His acid-fast smear for non-tuberculin mycobacterium also came up positive at that time. Basic lab work was normal. We do follow his hemoglobin A1C with his history of insulin or impaired glucose tolerance, but his IgE was also over 1,000. It was 1,877. So combined with the Aspergillus growing on the culture and the elevated IgE, we initiated therapy for ABPA. He had a PICC line placed. He was started on IV antibiotics for the multifocal pneumonia in addition to the ABPA treatments. He was provided tobramycin, cefepime, and Bactrim as his therapies to cover for his recent growth. He was started on corticosteroids for ABPA with a plan for at least 4 weeks and then repeat lab work. And we performed glucose monitoring during this time due to the increased use of steroids. His airway clearance was increased to every 4 hours. Normally, I think we start out about 4 times a day, but because he presented and we know at home his adherence is challenging, we always just increase it. He uses albuterol, and we use a Metaneb device at our facility when they're inpatient to enhance over the standard vest therapies. Most of our patients do feel that it helps more so. He got Dornase alpha twice a day and ongoing budesonide and formoterol twice a day. He did receive his supplements while inpatient, and he also received his enzyme therapy. When we asked to bring in his modulator therapy, because our hospital does not provide modulators in patients, no one was able to find it. And we did speak to his mom, who reported it had been at least several weeks since she'd even seen it. And then at one point, which made us all cringe, someone said, "I think we threw that out." So, oh boy. He did also get standard evaluations with our dietitian, our physical therapist, and a stationary bike was placed in his room at his request. So I am including a physical therapy evaluation just for the people here who know what this is. I rely very heavily on our physical therapist for summaries and outcomes and ways that we can help. And so this was our initial evaluation, which was discussed with me as being essentially okay. No significant or generalized concerns from the full PT evaluation, which is done for all of our patients when they're admitted. And there was one noted mild deficit with some rounded shoulders on posture. And so our physical therapists followed along while inpatient. They provide like stretches, exercises. They encourage them to obviously use the equipment and provide that natural, beautiful airway clearance. On hospital day 4, his follow-up lab work had returned, so it takes a while for the Aspergillus testing to return. His Aspergillus fumigatus antibodies were a class 5. And so just as a reference, his number was 64, and normal is anything less than 0.01. So his number was incredibly high. The highest score you can have is a 6, so he's pretty close. We wanted to wait for culture results, too, for the AFB screening, for the NTM, but he did grow a few Mycobacterium avium complex. So then we had to decide what to do because he had a positive NTM culture with symptoms and he has Aspergillus growing, and he's a patient who has really challenging adherence at home with a very complex social situation that I'll go into. He felt he was improving on steroids. We recommended bronchoscopy to obtain second cultures for mycobacterium growth and a chest CT to evaluate further before we decided on planning and therapy management. We wanted spirometry, but he was continuing to cough, so prior to discharge, that was our goal. And we discussed with him that he would need a 2-week admission at least for steroid management, IV antibiotics, and then to await what to do with that non-tuberculin mycobacterium while we planned. He panicked. He became very stressed and anxious. He took his pick out and eloped. And in our hospital, they called it code pink because children typically elope, but because he's 18, it became very complex. And so he left, which brings in the social aspect to this presentation. He has had many behavioral concerns in the past. As a fellow, I was very comfortable with him as well as a patient. Some of his behaviors became minor legal issues as well. And so in the past, he had court-mandated psychiatric support. However, when evaluated by a psychiatrist, they felt that he had significant cognitive delay and could not even participate in the sessions. Like his mother had to help for him to understand what the psychiatrist was even saying. And so for that reason, they just stopped. They didn't help to establish other therapies. They just said this isn't working, and so it was discontinued. He did have significant support at school that was very much so supported by our CF team as well, and they did diagnose him with intellectual disability on mandatory psychiatric testing. He had a 1-to-1 aide while in school and was unsuccessfully repeating senior year at this time. He struggled very much so with virtual learning during COVID, as many children did, and had significant delays. Our CF social worker and CF nurse coordinator were heavily involved with the school and his care and support plans. They had meetings with the school, would attend them with his family, his teachers, guidance counselor, to monitor the 504 plan, but also to kind of provide additional supportive measures. Despite this, he actually struggled with basic communication and comprehension. When we were trying to later discuss his bronchoscopy, and I said, your bronchoscopy is at noon, he asked me what that meant, what time that was. He would spell his name out loud at times and often call his mom to help with just basic comprehension. So after he eloped, our CF social worker reached out to the emergency contact, who was his mom. His parents have been intermittently involved in his care for a very long time. They have multiple children in the home. He cares for himself, but also takes care of his younger siblings, takes them to school, gets them dressed, feeds them. It's a single income household. They have significant financial stressors. They live in government subsidized housing with a state voucher, and they have a prolonged history of food insecurity. At times, his dad has expressed in clinic that they don't have time to stay on top of him in his care. It has to be his responsibility. This was when he was like 14, 15. They have too many children and too many responsibilities, so it's up to him. There were times that he would ask to come into the hospital and they would say no because they felt like he just wanted attention. And there were admissions when he was younger where we felt as a team that he was actually staying longer because of the food option, that he was staying to eat. And there were times when both parents stayed that we felt that they were kind of it was helping them with food and lodging and that kind of thing. Even when he's admitted now, I have to call down to the cafeteria and give them an extra, allow him to order all the food. He orders like 10 sandwiches. So we still have to even do that now. Mom brought him back to the hospital after our social worker spoke with her. We transitioned him to oral antibiotics and steroids. We did not place a PIC for safety. We wrote out the plan for his management on a whiteboard and took a picture in his phone, and then discussed what each pill and color looked like and what he would take and how often, and then also wrote that out for him. We set reminders with alarms in his phone for his care plan, so when to take his medications and when to come to his appointments. He declined bronchoscopy at this time and was discharged with a 1-week follow-up. He missed his follow-up appointment and presented 2 weeks later at an outpatient clinic at the front desk, just walked in and said he's having chest pain and shortness of breath and he needed help. During that evaluation, his vital signs were stable. He had some scattered wheezing on his examination. We readmitted him because we needed to get lab work and decide what to do with his management of care, and doing that at home has not proved successful. He was readmitted with a behavioral contract, so our social worker created a contract with him of what was expected of him during his stay, how he would behave, and what he would need to do if he wanted to leave. Essentially, he just needed to talk to us if he was feeling anxious, and we would try to either encourage him to stay or help with a safe outpatient transition. We also met with the inpatient team. We have great inpatient support at our hospital. We all decided that a PIC would not be placed. IVs would be used just intravenously from a safety perspective, and that we would meet essentially daily, talk about what the plan would be. So we started on IV antibiotic therapy. We scheduled his bronchoscopy. He was amenable, and we did obtain a CT chest. We set his admission goals as a team, and CF and ID pharmacy were kind of in the background because I said if the acid fast comes back positive again and he grows NTM on his cultures, we need to find a safe plan for management because weeks to months of IV therapy for this patient is, in my opinion, unsafe. So this was the CT chest on repeat hospitalization. I just highlighted a few of the key components here. On the left, you can see a right upper lobe wedge opacity. We believe that's actually been there for 6 to 9 months based on repeat imaging and which is not opening up. And so that's more of a chronic finding. On the right side, you can see a right lower lobe tree and bud of opacity. There's some inflammation there. When discussed with our radiologist, they felt this was maybe more indicative of the NTM infection, but also just showed some mucus trapping and signs of ongoing fungal infection. So we performed the bronchoscopy. Essentially, we wanted to open up that right upper lobe and get really good sampling. And so these are some images of the right upper lobe in particular. There was copious purulent secretions with mucus plugging in the right upper lobe. The picture all the way to the right shows essentially the plug. We instilled Dornase alpha on 2 separate occasions during the scope and used 60 to 80 cc's of saline, which is, for a pediatric scope, in my opinion, more than I typically use, and actually tried to auto PEEP and pop open that lobe by bagging, which was the most beneficial, but that plug still did not move. It was stuck. It was like glue. So we were able to get samples, but we discussed in the future that he would need steroids, increased antibiotic therapy, and potentially a repeat bronchoscopy. At the end of this hospitalization, he did feel significantly better. His symptoms had improved, and we were able to perform spirometry this time, which showed dramatic improvement in FEV1 by 28% since the beginning of his admission. But there was some overall mild reduction in his airflows, as you can see, that was still persistent. And this is not his baseline best. We did repeat lab work as well while he was there. We tried to kind of optimize our therapies and planning while we had him. The acid VAS spear was positive, but the culture was negative, which was reassuring this time, so we did not have to initiate NTM treatment yet. His IgE was improving, so from over 1,800, it was now 747 at the time of this presentation, and as of 2 weeks ago, it was actually 300, which is great. His Aspergillus antibodies also came back as negative, so they were responsive to steroid therapy, and his culture just continued to grow MRSA. He had no new bacterial growth. So he was discharged home at his request. We essentially made a deal that if he stayed for his scope, he could leave, and then we waited for final culture results. He was sent home on oral Bactrim or trimethoprim sulfamethoxazole, whatever, and corticosteroids with written plans prior to discharge. So we essentially took screenshots of all of his plans. We go over them. I try to have him repeat them back as best as he can, and then he went home. His mom was also involved this time as well with his consent, and the plans were discussed with her because he was living in her home at the time. We also created our contingency plan for NTM infection. So if he was to represent or have cultures to grow again, this is actually an oral therapy regimen they came up with that he could take for weeks to months if needed, which is significantly safer for him than placing a PIC and sending him home or trying to keep him in the hospital. We also came up with a second option of potential day medicine infusions of antibiotics, so bringing him in routinely and doing the IV therapy should the outpatient regimen fail, but we were all essentially crossing our fingers because his transportation has been erratic and his presentation to outpatient clinic is really independently driven. So some support following discharge that we felt was helpful, or at the time of discharge, we had all of his medications refilled in our hospital pharmacy. They were brought up to the bedside by the nurse, so we know that he at least went home with his therapies. His ETI therapy was additionally filled at our specialty pharmacy, but they were not able to be delivered before the day of discharge, but our social worker spoke with the mom who did pick them up the next day. We arranged transportation for him outpatient, so to give him a ride to and from clinic. I placed an hourly appointment reminder in his phone for 24 hours prior to his appointment that would ring every hour to alert him that he needed to be there. So the last hour it would stop, assuming that the car would pick him up. That was the plan. And we did speak with the family. Our social worker spoke with the family to encourage them to participate in his care plan because he got quite sick quite fast with many infections. We also started the transition process because we knew that this would take quite the long time. Normally we wait a little bit longer to start transition to the adult clinic, but we knew that we would need time with this family. So he had a virtual meeting with our adult CF center while admitted to at least make a friendly face connection and to establish one outpatient visit to start that process. So this case is a medically complex patient who presented with prolonged pulmonary exacerbations in the setting of ABPA and potential evolution of NTM. The medical complexity was compounded by concerns of poor adherence, social and intellectual limitations, but ultimately our multidisciplinary approach with constant communication did improve his overall patient care. I will report it's not perfect, and he did not show for that follow-up appointment, which I was like, we have nothing left. But so he did not show up, but he does provide, I think, improved communication with our team since then. So we're getting more text messages, more phone calls. When he runs out of medications, he's letting us know right away. And so even though his physical presence has not significantly improved, I do feel like he's participating more in his clinical care, which I think is necessary baby steps. I just have a few slides highlighting some of the recent data on the impact of demographics and socioeconomic status. And so despite advancements in CFTR medical care, there are significant disease disparities among our patients. Socioeconomic factors can be profound. As a provider, we often discuss the role of phenotype and how genes are expressed, but that's kind of where we start with families, right? We don't talk about all the other factors with them all the time. And I think it's important that we discuss their environments more so and how it impacts each patient's care. And so this was very helpful for me. Some of the implications that are important are the insurance status, geographic income measures, and education levels, both of patients, but also of our guardians in the pediatric population. And so essentially the overall arching theme is that lower socioeconomic status is associated with an increase in mortality for many reasons. So pertinent findings in the literature, patients from minoritized racial and ethnic backgrounds experience greater disease burden and worsening outcomes. In particular, I focus these slides on the Black population because of our patient and its relevance. And our Black patients are noted to have more severe pulmonary imaging in chest X-ray findings, but also CT scans. Pulmonary function can be lower in general in the population, up to 10% lower in the FEV1, and they report increased respiratory symptoms on standard screening tools. Income as a factor is important. There are several studies that show a profound difference of 44% increase in mortality among patients who are in the lowest income brackets compared to the highest income brackets in specific geographical areas. I do highlight one specific example here in the lung function, where a 5.5% difference in lung function occurs between the lowest income in this study of less than $20,000 a year compared to a higher income bracket greater than $50,000 a year. Food insecurity, I feel like I've attended several really good talks at this conference about food insecurity and nutritional outcomes. And as a general thought process, about 30% or up to 30% of CF patients could be currently food insecure, but data is still being collected. Education also matters, as we know, so lower than expected average educational level in parents and patients is also associated with a persistent decline in FEV1. So not just an overall difference, but every year the concern is that the FEV1 can drop by up to 0.05%. And so in a disease where we create modulators to stabilize and improve lung function, this is definitely counterintuitive. Insurance as well plays a role. So patients on Medicaid have an average lung function 9% lower than privately insured patients. And mortality is 3.65 higher in patients in that insurance class. Adverse childhood experience is a very interesting category, and it is definitely still being studied with research ongoing. There's concerns for excess stress in the home that can lead to diminished cortisol levels and persistent inflammation. So essentially a physical and emotional reaction are directly linked. And some overall ways of improving those barriers and limitations are here, which I think our educational committee is great at emphasizing. So partnership with the community, emphasizing patient and family advisory council, so relying on each other essentially in a way that's safe and we're able to do. Revising screenings to meet these unmet social needs, and so working on screening for food insecurity, providing financial support and resources. But one thing that I found interesting was also like finding a safe place for these kids to play, right? Safe physical activity, places to exercise, like outdoor exposure is great and improves lung function in some of these studies. And so like, where do these kids go to play after school? Like I never asked that, but it actually matters. And then partnership with our community and community resources as well, and CF Compass is one I just listed. And this is some of our awesome care team that I'm very lucky to work with, so thank you very much.
So if you have any questions, please make sure you either come to the microphone or put them in the Q&A in the app. The other thing I'd like to say is we asked our speakers to give us a fun fact about themselves. And I will tell you that Dr. Greenwald, she has never had a broken bone or been stung by a bee. And she was a French major in college, and her goal was to be a professional translator.
But I do love my job. So it all worked out.
I also want to just want to take this opportunity to thank Kim. This discipline group session was her idea. So I do want to thank her for coming up with this idea, and hopefully you all enjoy it and give us suggestions for next year if you would.
Hi, Dr. Greenwald. Real fast, you highlighted something that we've dealt with a little bit, but your patient presented with increasing symptoms. Oh, and by the way, you're 18. Mm-hmm. So you mentioned that he was going back to parental care. Have you guys had to do anything in thoughts of trying to help him find housing now
good
that
point.
he's 18.
So not specifically, because their dynamic is that he stays at different people's houses based on his dynamics at home. So I'm sure that will be a topic we need to broach in the future, but at the time, we actually oftentimes don't know where he's living. So he'll tell us he's at Aunt's house one time, or he has a new girlfriend he's staying with, and so he has not pursued housing. I do believe in the past we have worked with him on finding a job, and the high school was supposed to help with work placement, which I think did not work out, but I do believe it's been more focused on employment and less on housing.
Hi, I don't know where you got my patient stuff, but
Right?
good job, right? So I have a question, not really, because obviously you do everything that we all do.
Yeah.
How do you keep the team motivated to keep swinging and trying,
Yeah.
knowing that you're going to fail? I mean,
Yeah.
I don't mean fail. I mean,
I totally
you
know what you're saying. Yes.
challenges. Yeah. I just
Yes.
don't know. We have patients like this, and it's really hard at some point not to just go, whatever, they're going to do what they want, and we're here if they need us.
Yes. Okay. So, and also the sunshine and roses in the presentation, there were many times that we said, okay, whatever, right? Because you can only do so much. So when he didn't show up for his follow-up appointment, that was an okay, whatever moment. Like, we could not have given him any more reminders or any more support in that time. And so we certainly had those times, but I think it's two things that help us continue to work with families like this, because he's obviously also not the only one at every practice, right? One is it's little victories. So the fact that he called and came back in and then stayed for that admission once we were able to help was a huge successor for us. The fact that he was receptive to care really mattered. But we also have a CF huddle every week on Thursdays. And so I feel like we take that time to be like, awesome job, you did the best that you could, and we support each other with the work that they've done. And so I think that like if we continue to provide like internal hurrah moments, it becomes a little bit easier. We also all have a great sense of humor. So we try to make jokes and make light of what we can. But we certainly have the okay, whatever moments too.
So real quick, I have a question that was submitted through the app. When transitioning to adult care, do you speak with the team about all the social challenges?
Yes. Yes. We don't want anyone to be blindsided. And so we have a great relationship with our adult CF center, and we have quarterly meetings with them. And so if we know that there are pediatric patients on the docket to transition, we will discuss them mildly clinically, but also significantly socially. And so his name had been brought up several times as a kid who was coming down the pike. And then when it became a little bit more necessary that we had to start the process, our social worker reached out to their coordinator and provided some background on why we were moving things up and what we needed to do. And they were very receptive. So we discussed every aspect because we don't want to leave anything out that's important.
I don't have a question as much as a comment, observation. We have a new diagnosis, and the mom is very, very cognitively simple. She actually had a traumatic brain injury as a child, and she's so cute, and she tries really hard. But one of the things that I have to constantly remind myself, just kind of with our average intellectual level patients, but also especially with her, it really drove me home, was just how simple we have to do our education,
Yeah.
the wording, and with her in particular, like I thought I had a lot of my handouts simplified and using, very basic language, the whole less than fifth grade wording. And with her, I had to even go deeper with that. And
Oh, wow.
And at one point, I asked her, I'd gone through everything. I was going through cleaning and disinfecting instructions for the nebulizers, and I went through it all. And she's, yep, the whole way through. And then at the very end, I said, "Can I ask you a question?" And I mean it in the most kindest way, but can you read? And she said, "Yes, I can read. I just don't understand what I read." And I was like, oh, okay. Well, so it was like a whole, and so that is just something for myself with some of our more challenging patients, that I really have to remind myself, like,
Yes.
simplify it. And when you think you've simplified it, you probably still haven't
Right.
simplified it.
And that's the importance of Recite Back too. So thank you for sharing. Like, we do oftentimes say, like, can you please tell us what we just discussed? Like, what are you doing at home? What is the plan? And so I think that's an excellent point to make. But as you were speaking, I also was thinking that we have many patients and families who are very high functioning, who are very intellectual, but because cystic fibrosis is a very specific disease and overwhelming in every way, we oftentimes need to simplify even for some of our patients who have very high functioning families. And so it's kind of just an idea. It's a great idea to take a step back and just realize how we're providing education and communicating, because it directly drives care.
And I will just add to that, with this particular patient, we've taken care of him since he was an infant. We've provided Word documents for him that we've laminated with pictures, simplified words, how much of each medication he's supposed to take, what times of day he's supposed to take it. And still, I don't feel like, and we're not sure that the father can read. So and he's usually the one that brings this patient to clinic when he was younger. But we've tried everything we could to simplify and communicate, and it continues to be a struggle.
But thank you for sharing.
I have one quick question. Does your center, do they do home visits?
No, we do not do home visits. Actually, prior to COVID, we had done some home visits, but not for CF. But we don't do home visits. We do skilled nursing visits, though. He has not received those, I don't think, ever. Maybe when he was younger. He did. When he was younger, he did. But not in the recent past. But we do skilled home visits, and we have many of our patients now in medical daycare, which I feel like has been helpful. Because medical daycares provide us updated information. They tell us, weights and when airway clearances are being performed, and they can give us vital signs. So some of our patients who are tenuous do go to those, types of places. At the age of 18, we have not had enough. I would love to put him in medical daycare.
He was in a medical school. We have a
that's right.
medical school in our state, and he
Yes.
was in the medical school, but unfortunately, some of the behaviors he demonstrated there, he was not able to go back.
But we have had great resources for a lot of our patients. So we are lucky in that way.
Well, thank you so much. We're going to move on to our next speaker.
Our next speaker is Dr. Christopher Fowler. He grew up in Athens, Georgia, went to the Medical College of Georgia for medical school, and then the University of South Carolina in Columbia for pediatric residency, and the University of Alabama, Birmingham for pulmonary fellowship. He is now with us at UAB and Children's of Alabama. He does a mix of clinical work and TDN trials. He has 3 kids, 2 cats, and loves Pokemon. As you can see in the shirt that he's wearing today.
Thank you, Kim. All right. Let's see. How do I switch to the next one? Here I am. Okay. Well, I'm excited to be here. Thanks for inviting me to talk. A lot of what I was thinking about talking about was already done better by somebody else yesterday at 2 o'clock. So I'm going to fly through some of this. And I recommend if you get a chance to watch that one, I think it was recorded. You could go back and see that. But I'll hit the highlights and then try to get to the cases. All right. So I'm talking about my cases are about people who are having trouble with adherence now that they have Alexa catheter, Tizzy catheter, Ivor catheter, ETI, and then one other child who doesn't. But before the cases, disclosure. I have some funding from the CFF, but not from industry, and that's it. So we'll talk about what we know and what we don't know about adherence challenges. There's a really, really interesting survey work that's been done in the U.S., the U.K., and Canada. They asked people with CF, and they asked their family members, and they asked the providers who take care of them, what do y'all want? What's important to y'all? And one of the top 10 requests was, hey, how can we make everyday life simpler? Is there anything we can do to make it a little bit less of a burden? They did this survey before Trikafta came out, and then they did it after, and that was still in the top 10. So it's something that everybody, I think, that we talk to every time we have clinic is going to ask us because That's been my experience. Airway clearance, when they're asking folks, what are the most burdensome things that y'all have to do every day? Airway clearance is identified as the most burdensome thing. More than nebs, more than pills, more than enzymes and everything else that they have to do. And that's multiple surveys agree. There was the first study I wanted to talk to y'all about was called Tempo. Took place in Britain. It was all children. I'm a pediatric pulmonologist, so my bias when I'm reading about CF is looking at articles that involve children. So you'll have to bear with me if you're an adult caregiver. But they did surveys in children and caregivers and their healthcare providers. It was nurses, it was RTs, PTs, dietitians. 30-minute interviews. This is not a control trial. This is just asking people questions about their life. And the outcome, they kind of break it down into a bunch of themes. But the overall thing that people said was, my life is different. But they had questions. My life is different now. What's my life going to be like down the road? What do I need to do to take care of myself to stay healthy? Is there anything I don't have to do anymore to stay healthy? So they broke it down into the themes. When they put all the survey data together, they said, okay, here's one theme and here's some quotes that we got from folks that kind of fit this theme. And if you see a quote that you may have heard in your clinic before, I wouldn't mind if y'all would raise your hand or give me a little woo woo, okay? Or amen, whatever your preference, all right? So, theme number 1, changed my life. Sub-theme, doesn't affect me anymore. All right, there we go. Some people they're not coughing, they're not short of breath, and their lung function looks better. The second sub-theme in that one was I feel good. I feel healthy. But a lot of these people don't know what it's like to feel healthy. I have 3 children, all relatively healthy. They get colds and stuff like that, but they've never had to stay in the hospital. They go to the doctor for their shots, and that's it. So I don't think I really have a good understanding of what it's like to have a sick child, or what it feels like to not feel healthy. That's just my bias. So feeling healthy for the first time. Also, the last statement was something I could relate to. Parents reported having fewer fights about spending less time on CF care. I have 3 kids that are healthy, but I still have to get them dressed and take them to school in the morning, and that is a fight. So I don't think I really understand what it's like to try to do airway clearance and all the other things that they have to do every day. The second thing that they brought up was your entire life is dictated by this CF timetable. So every day, wake up, you gotta take your enzymes, eat something fat, take your ETI, do your nebs, do your airway clearance, do your huff coughs. Get dressed and also, make sure you did your homework and all the other things that everybody else has to do every day. And it is very time consuming. And I like what this dad said, because it reminds me of when I was in medical school and I went to Augusta University, or MCG, and the first time I walked into a clinic, what I heard was, blow, blow, blow. And I was like, what is going on back there? And it's like, oh, that's just the PFTs. You'll get used to it. And now it makes me happy whenever I hear Valerie saying, blow, 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 every time I have clinic on a Tuesday. But this dad was saying he used to be stressed, shouting at his kids, blow, blow, count, concentrate, all this stuff. And he said constant nudging to make sure everything gets done the right way. And that's exhausting. And this is still a lot of the same idea. They feel like after they started the ETI, that daily burden was better. People said, it's ridiculously fast. How you can get ready in the morning, 10 or 20 minutes. And I'm like, well, I don't know if I could do 10 or 20 minutes. These are professionals, though. They're used to cramming an hour and a half or 2 hours of stuff into a 30-minute morning. And then people talking about how much has changed. But the overall, I think, idea is life is easier. The third theme is it's about, okay, there's this idea out there floating around about could treatment be simpler? But the question is, I hope it could be simpler, but is it safe? And I think the first statement is from one of the healthcare providers. I don't know if it was a RT or a dietitian or a nurse, but I think I've had the similar thought when I hand a teenager a list of all the things that they're supposed to do every day, and I think, I wouldn't do all that. I wouldn't want to do it myself, but we're asking them to do it every day, forever. And I think a lot of us in this room probably feel like it would be hard to do. But some of us in this room, I know, do it. So kudos to y'all for putting in the effort. And if there's anybody with CF listening, we appreciate these efforts, even if we don't personally have that experience or understand it the way you do. And then the parents kind of had mixed feelings. Some of the parents and I think I've seen this in clinic. If I hear another hoo-hoo, I would rather just do it, even if it's not necessary, just to know that you did everything you're supposed to do, everything you could do to keep your child healthy. I think that's a very common sentiment. Everybody just wants their kid to have the best opportunity to be as healthy as they can for as long as they can. And nobody wants to be the person who stops doing something that they're supposed to be doing and then find out later, like, oh, no, my child or I personally lost this many points of lung function because I stopped doing the stuff that for my whole life I was told I got to do every day. But all of a sudden I didn't feel like I needed it and I stopped, and now, that's some permanent damage to my lungs. All right. This statement I know I've heard from multiple patients. I'd rather take a break just because, let's see, if you don't try it, you're not going to know. I can't tell you how many teenagers. I take care of almost exclusively teenagers, and a lot of them said the same thing, like, well, can't I just try? What if I just do it? And most of them don't even ask, like, they just do it. They just stop doing the stuff. And they all have this idea, like, I can just go back. Because I think a lot of people don't understand, like, sometimes some things that you lose, you can't get back. And then a lot of patients, and I think some providers too, have this idea of maybe they could just do things PRN. And then just kind of watch, maybe make a tiny change. Like in this case, they talked about doing different numbers of cycles of PEP. Oh, maybe we just, decrease that number. Or maybe I just don't do the huff cough, but I do some of the other stuff. Or, all the little things that people bargain. And then at the end of the theme, they also briefly mentioned exercise, but there wasn't much said about it. The fourth theme, and I think we're getting close to the end of this study, is a lot of people just don't know. They don't know what to do. They don't know what to think. They just know they feel better, and they ask that question, like, if there's nothing to cough up, why should I do it? And then I've had this thought: the simpler we can make the treatment, the better, because they're more likely to do it. It's kind of that same idea of when we debate, like, hey, what's the best way to do airway clearance? Is it vest? Is it aerobic? Is it X, Y, and Z? Well, it's the one that they're going to do. You can maybe there's an excellent way to do air clearance, but it takes 2 hours every day. Nobody's going to do that. So you get folks, you kind of negotiate with folks, do the thing that you can do every day and do it well. So I have that same idea. If I could make something simpler and people would be more adherent to the simple thing, maybe that could potentially be better than having a very complex plan that nobody does. And then one of these kids was like, I've had a taste of the good life, not having to do all this stuff. And I think, we're most of us adults, and, we all have adult health problems. And it's like, we've probably all been at a diet at one time. And it's like, okay, you cheated. You came to conference. You ate some stuff you weren't supposed to eat. And you had a taste of that good life. And now you got to go back home in a few days. And it's like, well, I'm surrounded by my family and friends, and they're going to know I'm not supposed to be doing this thing. I really missed that good life that I had a few days ago. Similar idea. So I think the overall point of the study was people said life is better, but they want to know, is there some science that can tell us what to do? And it's a mixed picture right now, but I think if we had this same meeting next year, we might have more information. I won't spend a ton of time talking about the next few studies because they've already been discussed, and there's a few poster presentations about Simplify or talks about Simplify. But we were lucky enough to be one of the centers where patients were enrolling in this trial, and it was really fun. So children and adults all across America had the chance to either stop taking their hypertonic saline or stop taking their pulmozyme, or maybe even both, or keep taking it and get paid to do that. The comparison was just to, comparing people who stopped to people who kept taking it. And it was about 6 weeks. And at the end of the 6-week period, they saw, okay, your lung function really didn't change that much. And we'll kind of look at this. I made it impossibly small to read, but this is just the numbers. So, this is roughly 200 folks in every group. People who kept taking it, people who stopped taking it, people who kept taking saline, people who kept taking pulmozyme. And a few people dropped out, but there weren't a lot of safety issues, which makes you feel good about the trial. So the graph in the A, the top left, shows, the blue is the saline, the red, sorry, I'm colorblind, it might be purple, is the pulmozyme. And, you see those little circles in the triangles for stopping or not stopping, and they're right about in the same spot at that 6-week point. And then, there's a few more graphs in here, but I don't think we have to get too deep into the nitty-gritty. Just know, hey, 6 weeks, some people kept doing it, some people stopped doing it. Their lung function was really about the same. And there's a few more endpoints, but that was the main endpoint. And this is just a chart showing that the groups were roughly the same. So same number of men, same number of women, roughly the same age on average. I think something important to know about this simplified study is that a lot of these people were very young. I think the average was in the early 20s. And then a lot of these people were really healthy. I think their average lung function was 94 or close to that. So this study is only applicable to a very small group of our patients, adult or pediatric. So the conclusion of the study is there might not be a big difference in your lung function if you stop taking your hypertonic saline or your pulmozyme at the end of 6 weeks. And I think they're doing a presentation on what about those people who stop doing both later today, but I haven't seen it yet. So if you get a chance, that might be a good one to go to. But it has some, it's not a perfect study. It doesn't answer all the questions that we have. They didn't even talk about, doing your aerobic or your vest or anything like that. And it's a very short-term study, so we don't know. What about if you did it just another month or two, would that make a difference? But there is a longer version of this study, and there's some other studies that are going to go for a little bit longer durations. I think that will also help answer this question. So this CF Storm trial, it's already been spoke about at the conference, but it's a similar idea. 12 and up, people taking their ETI, they're going down to people with a little bit lower lung function, not all the way down to 40. And they're just looking to see, is there a difference at a year? And then Hero 2 is another one, but here in America. And it's this one, there's an app where people are self-reporting their symptoms and things like that, and also describing, hey, what is it I did for my treatments today? Did I do my airway clearance? Did I do my pulmozyme? Did I do my hypertonic saline? So I think this one will be I'm really looking forward to learning more about this. So that's what we know, but it's really mostly what we don't know. There's a lot more we don't know than what we do. And we're still left with that question when the patient's sitting in front of us, what do we tell them? What kind of advice can we give them? So I'm going to present some cases. The names are fake, but the stories are real, just like Law and Order. So this is Forrest. All right. They're also all adolescents, because that's all I take care of. And so this is a healthy adolescent taking ETI who, without my advice, stopped his nibs and his airway clearance on his own. And, I made up the dates and times, but this is a real patient that I know. So roughly around the time that Trikafta comes out in the fall of 2019, it's not long after that they start taking it. They get a big bump, maybe went from the mid-80s to 105, 107. And then maintained it. Even after they probably stopped doing all their stuff, I would say within a month or two of stopping their Trikafta. And really didn't seem to suffer from that. So, we had some back and forth debates about hey, I would like you to do these things. And of course, the patient says, well, all those things that you heard from the British survey, I don't have anything to cough up. Why would I do that? I got too much fun things to do, and I don't have any time for your stuff. So I'd just like to see if we can get a little informal vote. Like, who in this room would tell them, hey, do something every day? All right, that's a decent. Who would tell them, all right, you're good. Don't worry about it. Nobody. Okay, I guess I'm in the wrong. No, I'm just kidding. So in cases like this where I have patients who are really healthy and they stop doing a lot of their treatments and they maintain their health, I try to negotiate a little bit with them to see what's the bare minimum I could get you to do every day. Because I have some of those same thoughts as the parents, like, what if this isn't as, a few years from now, you don't have the same benefit that you had when you first started? What if you start to lose your lung function and we can't get it back? What if you start to develop some bronchiectasis? Or just, and this is like people being people, we're forgetful. What if you forget how to huff cough? What if you lose your aerobica, you lose your vestas in disrepair, everything goes wrong and you get sick. And now you're coughing and wheezing and struggling to breathe, and you don't even know how to take care of yourself anymore. That's always something that's in the back of my mind. It's really easy to forget how to do things that we do every day. People always talk colloquially about like, oh, it's as easy as riding a bike. You don't forget how to ride a bike. But if you watch an adult try to like rollerblade or ride bikes, we're not very good at it after a decade or two of not doing it. So I think it's very possible for people to lose these skills. All right. Are we doing good on time? Okay. This is another patient. This is Rosie, another healthy adolescent with CF. So this is somebody where you can have those simplified thoughts like, hey, your lung function is, in the 80s or 90s. You're pretty young. Maybe you could stop doing things. But of course, before I even got to tell her about the results of the simplified study, she had already stopped. So they beat us to it by several months. So you can see she's cruising along near 100. She's a very healthy young lady. And then starts taking Trikafta, boom, 130, setting records, and then starts to creep. And this was somebody who, during the pandemic, took up CrossFit and was probably one of the fittest people I've ever met. I was afraid to tell her you had to do things. I thought she might beat me up. But we had that conversation. Hey, your lung function's dropping. What's different? And, she's very bright and just came at me like, I haven't done my airway clearance in months, and I don't do my NABs, and maybe I need to start. I said, well, you're very insightful. Let's do that. So kind of negotiated. CrossFit, I don't have a CrossFit gym. I don't go to a CrossFit gym, but I understand it's intense. And I said, that's, exercise can be airway clearance for someone or adjunct to airway clearance, but I think for you, in your case, you need to also do your airway clearance. I want you to do your huff coughs. I want you to do your aerobica at least once a day. And if you can do it more, great. If that's all you can do, fit into your college schedule and everything, we'll take what we can get and we'll watch your lung function and we'll see what happens. And slowly, she started getting back up near her 130s, near her record. All right. This is Ash. Had severe lung disease before ETI, down near 20. Occasionally would dip a little bit lower than that, but started taking the ETI and started to climb. This is a patient who previously had declined a transplant, wasn't interested, didn't want to go down that path, and now was maintaining a relative state of health, rarely having an exacerbation, maybe admitted to the hospital once a year over the course of the last 2 years, and still climbing. She hasn't peaked yet, which I find fascinating. And I think there's some data out there, when I was reading French papers, they were looking at their transplant lists, and their lists just shrank because all the people who were on their waiting list to get a transplant came off. Not all, that's an exaggeration, but many of their patients became healthier and were no longer qualified or met the criteria to get a transplant. You know, you could argue that, yeah, she still meets those criteria, but she's still not interested. But this is, I think this is a case that's made us all very happy to see that, hey, even in severe lung disease, this medicine can be very helpful. And what do you think I told her to do? Well, you're so healthy now, you can stop. No. Yeah, immediate no. So she knows what she needs to do to stay healthy, and she's doing it. And I just try to be as encouraging as I can every time I see her, and just be her cheerleader. And this is one of the last cases. So this is Augie. He does not qualify for a modulator. He just doesn't have mutations that would respond to that. And he's experienced a gradual decline in his lung function over time. And he's had things like ABPA and NTM, little bumps in the road. And of course, you know, he's a teenager. He reads social media. He knows the news. He has friends. And he knows that some of his friends don't have to do his stuff anymore. And I think that's been stressful for him. But I think, you know, we're always trying to be mindful that with all these great things that are happening, we still have patients like Augie who need a lot of attention, and we need to maintain our skills. You know, we need to know how to teach people how to do these things to maintain their health, and we can't forget it ourselves. All right. And then I think there's a few more questions that folks might have in the room, like, what about a sick day? You know, what are we supposed to tell people to do on sick days? None of these studies had anything to do with a sick day. So I think we're safe to say that when someone's sick, they should do their airway clearance. But there's no evidence. But my own personal opinion, I think I said this before, it's easy to forget how to do things, even things that are important to you. And I think good habits, you know, we talk about all the good changes in ETI. What I find is that I'm starting to have to give people advice that I would give to anybody. You know, if any of us go to the doctor's going to say, you gained weight. You know, how often are you exercising? You know, how often are you drinking? Are you smoking? You know, so all this life advice that we go to our physicians for is what they need. And we need to teach them that their good habits are essential to maintaining their health throughout their life. They're going to live as long as me, you know, and they need to know how to take care of themselves. They need to know, you can't eat too much. You got to stay active every day to be a healthy adult. And I think it's a lot easier to maintain a habit than it is to try to fight for it to get it back. So if we have all these kids who've been doing airway clearance for, you know, about a decade or, you know, however old they are, I think it's easier for us to tell them, like, hey, keep doing the things that have kept you healthy. I think it would be harder for us to say, oh, we'll just take a break and then try to relearn how to do it later in life. I don't know if that would work. But of course, you know, that's just my opinion, and it's worth what anybody's opinion is. So take it with a grain of salt. And then I would hate to give y'all any recommendations that get contradicted later by, you know, some study that gets published next year, like Storm or anything else. And then another question I had is, what's the best airway clearance technique now that we have ETI? And, you know, there's no new science on that. It's just, hey, do the things that we know we need to do. And whatever, you know, for these teenagers, it's, what do you have time for? You know, you don't have time for your vest? How about I hand you this little plastic toy aerobic and you can do that on your drive to school, or, you know, wherever you can help them realize, like, they can fit it in their schedule. It's a joint decision making. It's that, I don't know, it's like salesmanship almost. It's that affirmation. It's the positive motivational interviewing, or the partnership enhancing techniques that we're all learning. So I think we still need to keep up our skills to help them maintain their health. And I think that's it. Thank y'all.
Does anybody have any questions for Dr. Fowler? If so, you can come to the microphone or submit a question through the app. We have time for just a few questions.
Hi, Dr. Fowler.
Hello.
Thank you for hitting on my clinic. Though you don't come to my clinic, it's pretty cool to talk. After listening to the 2:00 yesterday discussion, the Simplify trial was such a short period of time. With the patients that you guys had in your study, has anyone done follow-up imaging to see if these patients who have electively randomized themselves into the I'm doing or I'm not doing, to see what retained mucus or how the airways are looking now that they've opted out of their treatments?
That's an awesome question. I believe, I wish I had a better memory. It's either today or tomorrow. There's a talk about mucociliary clearance where they were doing these MRIs and watching the mucus move up the airway.
Okay.
So that would, they're going to present that data. So go to that talk. As far as personally in my clinic, I haven't ordered any extra imaging beyond annual x-rays that, we were doing before. And, yeah. Does that answer your question?
It does. It's just, 6 weeks is a real short period of time.
Yeah.
And as you mentioned, social media, we, in general, everybody got really excited last year after Simplify. And patients hear things, and they're all in chat groups, and they're all in rooms. And again, randomize themselves to the not or the am. But I feel like we're seeing patients who are now going from that pinnacle and we're rolling away. Yeah. And it would be interesting to hear if anybody's done anything to follow up. So.
I think the practical way that I deal with that in the clinic is keeping an eye on those SMART reports. And you get to see that PFT, not just at your visit today, but like, ooh, okay, over the last several months and years, are we creeping? Because when you drop from 130 to 126, like, nobody worries about that. That's not very concerning. But when you go from 130 to 100, you're like, okay, even though we only crept down by 1 or 2 points every visit, over a year, that's a lot of creep. So I think that's the way I deal with that practically, is try to keep that big perspective and then show it to the patient and say, hey, here's your report. Look at that creep. What are you not doing now that you used to do? Or what's different? That's a little accusatory. That's coming in hot. I think you approach it more like, hey, you used to be here. Look at your bump after ETI, and now look at your creep. What could we do different to help you maintain that high level of health that you had 6 months ago? So that's how I'm dealing with it. Yeah.
I have a question more for the audience. We know that the role of the dietitian has changed in the era of highly effective modulator therapies. I'm curious to know what physical therapists are doing. I know previously, at least at our center, we would have the physical therapist recommend pulmonary rehab or things like that to help build their lung function, their overall health, muscle strength, things like that. What are people doing now with patients that feel so much better and are feeling like they can be more physically active? Any PTs in the room? Are there any PTs in the room that can? Yes.
No, he's just saying.
Oh, he's saying
Going. Okay. All right. So just a thought. I'm curious to know our physical therapist. We only have for 2 hours a week, so it's going to be interesting to see how her role changes or what she does differently with those that are on highly effective modulator therapies.
Yes, and I need to apologize to the PTs in the room. I am ignorant about a lot of the exercise science, so I didn't put much of it in the presentation. But that session yesterday at 2 with the RTs and PTs, that was enlightening. So, yes, I am excited about exercise, but I want all my patients to do both. I want you to huff cough after that basketball game. I want you to, carry your aerobica on your way to your CrossFit gym or wherever you're going. I do not own stock in CrossFit, y'all. That's just the only exercise I've heard. Look at little Rotan. I walk.
Okay, we have time for one more question, if that's okay, or two. You have a question also? Okay.
So I've been in the outpatient teaching role for just a little bit over a year. Prior to that, I was hospital-based, so seeing them only when they were sick and doing obviously all treatments on deck. But for that age range that is not able to do a PFT and show them FEV1 data, you're declining, you're going up, how do you convince, like most of my patients, when I came to outpatient, they were already on a modulator, and these 4 or 5-year-old parent, 4 and 5-year-olds, they're like, they've never had a cough, they've never had a productive sputum. How do you keep convincing them? When their parents are like, we've never seen that. They've never had an exacerbation. Why are we still doing this?
Yeah. I'm going to give you a flippant response and then a real one. I don't take care of them. No. But I would say it's like we do a lot of asthma care too, just being pulmonologists. And we have to teach people to do things every day that they don't want to do. And sometimes that's things that are just as simple as like, putting a spacer mask on your kid's face and getting them to take their puffs. And almost everything that pulmonologists and our teams ask folks to do is stuff that nobody wants to do. So I think it's a matter of like showing them how to do it, giving them ideas for how to make it, more tolerable for their kids. Whether it's, sometimes we give folks this spacer and say, give it to your kid, let them play with it for a week before you start using it. Or, they have the little decorated ones that look like penguins and animals and such like that. I think you have to work with every family to find something they can do with their kid to make it seem less like a chore and more like something fun. And then just emphasize like, hey, you're healthy today, but you're going to have sick days. And eventually you might have a decline. So we need to learn how to do these things now so that when you need them, you got them ready. I think that's how I approach that.
I just wanted to say, I work with adults, but I tell my patients, as far as the Simplify trial, that it was a very short trial, but also that the people who stopped one nebulized medication or the other did maintain their airway clearance techniques through the whole 6-week study. So they didn't give up everything. Yeah. And that's sort of the ace in the hole that I use to say, we don't know, we got to be careful and try to convince people to do something.
And that's true, I think, also for the STORM trial. So they haven't specifically told anybody or randomized anybody to discontinue their airway clearance, but I think with the HERO 2 trial, they are monitoring self-reported airway clearance. So that might be when we get more data about the airway clearance specifically that we don't have yet.
Thank you, Dr. Fowler. So I have the pleasure of introducing our next speaker, Dabney Edson, who is a face of NACFC. We see her in a lot of things. She's very involved in CF care and the NACFC. She is a graduate from the respiratory therapy program of Augusta University. She has 4 years of experience in adult critical care and 22 years of experience in pediatric and neonatal critical care, including 17 of those being a member of her hospital's pediatric neonatal transport team. She has experience as an adjunct instructor at the university, or I'm sorry, at the university, yes, and also taught neonatal pediatric respiratory care, advanced mechanical ventilation, and clinical instruction to respiratory therapy students. She was an active member when her CF Center participated with the LLCB project, sponsored by the CF Foundation in 2007, and also 2016's Fun LLC. That was fun. That was a great one. Dabney transferred back to the neonatal and pediatric respiratory care department at AU's Children's Hospital of Georgia in May 2010 and continued in her role on both of the adult and pediatric cystic fibrosis teams, serving approximately 180 patients between the two centers. In 2013, she began a pediatric focus to expansion of the CFRT specialist role. She has participated as a session moderator at the NACFC, co-facilitator for the CF Foundation's respiratory therapy mentoring program, which this is her last year. We're very sad about that, but she's got great people coming after her. and the co-chair of the CF Foundation's Nebulizer and Compressor Accessibility Task Force. She has published 2 abstracts regarding airway clearance reviews and the use of high-frequency chest wall oscillators simultaneously in siblings with CF, and is co-author for a manuscript in Respiratory Care Journal publishing those findings. She continues to be actively involved and see her CF patients in clinics. So if everybody could please welcome Dabney.
Hello, good morning. Thank you for having me. I want to really thank Dawn and Kim for inviting me to present this patient of ours because he's been a little interesting for us. Many of the challenges that I have peppered throughout the presentation are not going to be unique to him or to you guys. In fact, we share several of these types of challenges. It's more the osteogenesis imperfecta element of it that was stumping. And I posted this on the CF respiratory listserv because I really wanted to get other brains that were smarter than mine on the case. And so I would welcome any thoughts and feedback that you guys have. Hold on, let me. I have nothing to disclose related to this presentation. This was my interesting fact. One of my best friends has a sailboat, and she sailed all down the west coast of Mexico in 2022, or in 2021 and 22, and I was able to fly down to Panama City and join her as she sailed through the Panama Canal on her boat. And not only did I just get to have, I wasn't like just eating bonbons and sipping cocktails while we sailed through. I was actually a line handler. She put me to work. I had to earn my keep. And the picture on the right to me is just mind-blowing. That's from one of the sky cameras in the canal. And we were partnered with this huge oil tanker as we went through each of the locks, which you can see on the left picture, just how big it is. But then from the sky camera, that little tiny boat right there, that's us. Okay, so I want you to meet SB, who is now 2 years old, who has cystic fibrosis as well as osteogenesis imperfecta. He was born in July of 21. He came to us as a transfer from an outside hospital. He was a 38-weeker term baby that was born with a meconium ileus. He was intubated at the time that he arrived due to apnea. At 2 days of life, he went to the OR to have 10 centimeters of non-viable small intestine bowel removed and returned to the NICU status post-ileostomy. That later got reversed at 2 months old. The CF newborn screening came back with his genetics being Delta F508 and this 2490 plus 1G arrow A with sweats pretty solid diagnostic 98 and 95. The parents rarely visited. This was our first red flag in the NICU. He stayed with us in the NICU for 3 months, and they were rarely there. And when they did come, they just showed up. They never kept, when we tried to schedule them to have conversations and do education, they often just didn't show. When they would come, and they just would pop in, and then they would stay very briefly. Like, they lived an hour away. So they would come and stay for 15 minutes and then bug out. So that was kind of concerning. And then a very passing remark from the father when we tried to explain, like, hey, your baby's came up positive for cystic fibrosis was like, oh yeah, all my other kids have that too. They break their bones all the time. So we were like, what? Okay. So a little more conversation, a little more digging led us to believe that he was talking about osteogenesis imperfecta. So we submitted blood for collagen and genetic testing and got that official diagnosis at over just a month old. So that led me into diving down into what does osteogenesis involve. And I learned that there were up to 8 different types. Type 1 is the mildest form, and bones are likely to break at this point from just mild to moderate trauma, with most broken bones occurring before puberty. Very little slight changes in stature as the child ages, some loose joints, muscle weakness, a triangular shaped face, Curved spine later in life leads to the potential for compression of the vertebrae, and then, of course, some lung involvement with that. Mild to even no bone deformities. Possible hearing loss, which that was a red flag for us should this kid ever need inhaled or IV tobramycin, which, spoiler alert, he did and does. And then at this point with type 1, he has normal collagen structure, but less than normal amounts. Type 2 is the most severe. That's usually death at birth or shortly thereafter because of the inability to breathe. Numerous broken bones while in utero, and severe bone deformities, very small stature, and hypoplastic lung development. Type 3 is severe, but not as severe. It's the most severe among those who survive the neonatal period. And it usually results in the greatest number of physical deformities, very easily broken bones caused by very little trauma over their lifetime. Often broken bones are present at birth. X-rays often reveal healed bones from bones that have been broken while in utero. That to me was pretty fascinating. Small stature, barrel-shaped rib cage, also triangular face, also possible hearing loss, also possible lung problems that worsen with age. And then types 4 through 8 are really not that much more significant. They don't add that kind of much more concern or information. But we were very relieved to learn that our little guy had type 1, which was the mildest form. So we had something to work with. So our first challenge came in the NICU with parental education due to their rare and unreliable and very short visits. So not only did we have to talk to them and educate them about cystic fibrosis, but also about OI. And not only understanding the diseases, but treatment plan for both. How are we going to accomplish this when they really didn't grasp the importance of either? Our second challenge became, what form of airway clearance could we do with this baby that would be safe and effective? So the first challenge, not too unique, not too different from what each of us experience with just cystic fibrosis, but what form of airway clearance was really safe and effective? And that's when I turned to the listserv and posted the question to try to get some feedback from all of y'all. So we reviewed the list of airway clearance choices that we had with this baby. We decided against manual CPT or postural drainage and percussion because of the questionable bone integrity. We didn't want to cause any harm. Of course, the vest is out due to the young age, the lack of head and trunk control, but then also when he got older, would it even be a possibility with the compression on the rib cage and the shaking? Would that be safe for his bones? Oscillating PEP therapy was not a choice because of his insufficient expiratory airflow at such a young age. Of course, autogenic drainage and active cycle breathing techniques, this was just a baby, so there's no way we could really teach that. So that led us to either PEP or IPV therapy or oscillating lung expansion therapy as possibilities. But then we started questioning ourselves with him being a baby, we would have to provide these therapies with a mask, with firm pressure over the nose, the cheekbones, and the chin. Would the facial bones hold up to that pressure? And especially with IPV therapy, adding additional, we're IPV users compared to OLE. So, the pressure that you have to place on the face in order to keep a good seal and provide that pressure, would the facial bones hold up to that? So we decided to play it a little safe and go with mask PEP therapy, start at a lower 10 centimeters of water setting. We added in albuterol MDI, and then we started him right away on hypertonic saline 3%. We were concerned because at his 3-month mark within the NICU, he was already colonized with MRSA. Not a good sign for such a little one. He came to us in the CF outpatient at 3.5 months old. So he was discharged from the NICU at 3 months. Half a month later, we saw him in the clinic, and only mom was in attendance. Every visit after that, it was just mom. We learned from her that they have 4 other small children at home, so this little guy was their 5th child. All of them had OI. Dad also has OI, and no others had CF. She was very happy about that we know of. So we saved that little bit of information later. We prioritized getting her on board with the care. And then kind of going back to our NICU stay, one of the other challenges when we initiated mask PEP was that this was a therapy that the inpatient, we don't really use that very much on the inpatient side. So getting the RTs familiar with it, comfortable with it is not necessarily an issue because, we do bag masking all the time. So, to do your EC grip and apply firm pressure wasn't an issue, but to talk with them about the device. And that's just me. So I was having to catch different people on different shifts. I was texting RTs at night, are you comfortable with this? What questions do you have? Please make sure we do 6 cycles of 15 breaths. So please, remember the protocol. Please remember to use a filter. We don't have a good way of disinfecting the PEP device in between each use. So we were using ventilator filters between the mask and the device to try to keep the device clean. Please remember to wipe the spacer down the mask with alcohol. So this was an ongoing task for us to get these people, not comfortable, but just consistent. So back to the outpatient visit. Only mom was in attendance. We got mom on board. She was very interested and eager to provide care. She seemed to really grasp what we were teaching. It was another one of those situations where it's like, yep. And I'm like, well, you're yepping, but are you really following? Are you really understanding? And she seemed to, I try to reword my questions away from yes or no answers and more open-ended. Tell me what you're doing. Tell me how you're doing it. Tell me how long you're doing it. And she really had all the right answers. So we were encouraged by that. But then it came out that Dad is not on board, and he was really giving her a lot of grief at the house. She's the primary caregiver for all of these children and the dad. It was a very kind of traditional family situation where she does everything. And then on top of that, the father was giving resistance to the PEP mask. He's like, you're smothering that baby. You need to stop doing that. He's healthy. He's fine. Look at him. He looks good. You don't have to do all of that. So she was getting a lot of pressure from him, which led, again, circle back to our original challenge. How could we provide effective and safe airway clearance at home with this essential single mother doing everything in the household and little buy-in and no help from the father? So we figured that we really needed to get a consult from the Osteogenesis Imperfecta specialty clinic. So we really shifted our attention to encouraging her to make that appointment, go get seen, go get established in their care, and then we could consult with them to try to get input on, is the vest going to be safe for him at a later point? What other forms of airway clearance could we do? The problem for her was that the only OI specialty clinic is available in Atlanta, and that was a 3.5-hour drive for her. She's already driving an hour to come see us. Dad is not supportive. He wouldn't watch the other kids. There was not grandparent support. So how is she going to get to Atlanta with all the other kids in order to do this? And then in addition, Dad was telling her, don't do that. You don't have to go. That's that CF clinic just causing problems, making things worse for us. You do not go. We consistently urged her to keep this appointment or to just get the appointment and then complete the appointment over a 10-month period. At this point, I think it's worthy of looking at some x-rays. So this first one was when he was 4 days old in the NICU after he got extubated from his ostomy procedure. So at the time, we were encouraged. Lung fields looked good. Almost 5 months later, still clear lung fields despite the persistent MRSA colonization. So we kind of thought we were doing good with the PEP. I can't point, but look at the one on the left. Do you see the screws in his arms? I found that very interesting because he'd had no procedures for that. I went digging deep into OR records and procedure records, and I'm really not sure what that is. But anyway, that's got nothing to do with the lungs. He had no operation or no orthotic procedure, for that. So, but anyway, back to the lungs. At 5 months old, despite the MRSA colonization and with the PEP mask and albuterol and hypertonic saline, we were encouraged because his lungs still looked in pretty good shape. We also did a skeletal survey. when he was 1.5 months old, and that showed that he had wormian bones but no fractures. So we were encouraged by that as well, and that seemed pretty consistent with the type 1 form of OI. His outpatient clinical course became concerning. He had multiple pulmonary exacerbations. He had 2 significant ones within his first 5 months of life. At that point, they were resolved with oral antibiotics. So he would get sick, he would get better, he would get sick, he would get better. He also came up COVID positive during this time period, with his first young 5 months. He became colonized with Pseudomonas at 7 months old, so we started him on cycled inhaled tobramycin by the time he was 8 months old. Remember that hearing loss part of OI? So that came up with our 5th challenge, like how could we get the mother and then both parents to understand at this point the urgency, which we felt became urgent, not just a recommendation, but a pretty important and urgent OI consult so that we could proceed with airway clearance in a more effective manner. So we sat down and reviewed our airway clearance choices again. Manual chest physical therapy, postural drainage, and percussion still didn't seem like a safe option for us. He was still too young for the vest, and also even if he was old enough and big enough, would it be safe for him and not crack ribs? Oscillating PEP, still too young. Active cycle breathing, autogenic drainage, still too young, inability to follow directions and coordinate. IPV and oscillating lung expansion therapy for the home did seem like a very tempting choice at this point. I'm a big, firm believer in IPV. I'm a fan. I love it. I think everybody should do it. I've seen it do really remarkable things. However, we didn't want to pull that trigger on insurance and have them pay for a high-cost airway clearance item if at whatever point he could keep that OI consult and they said the vest would be safe, because we felt like the vest would be a more reasonable option for the mother to accomplish at home with everything else she had going on. So we just continued to encourage her to keep the OI appointment, and we continued with mask PEP. At this point, we increased settings from 10 up to 15 and then 20 centimeters of water. We talked with mom about starting IPV or oscillating lung expansion, but we just continued to wait for her to complete the OI consult so we could have some recommendations and some guidance. At this point, he became hospitalized for a pulmonary exacerbation and a bowel obstruction. He had an exploratory lap at 10 months old, and during this inpatient visit is when we added in Pulmozyme. Because of the concern for worsening pulmonary status, with all of the exacerbations, the colonization now with MRSA and Pseudomonas, we also had tried to get x-rays previous to that admission, but mom would just leave like the way we're set up is that we either have them get the x-ray before they come to clinic, or they'll have their clinic visit and we ask them to swing by radiology on the way out, and they would just leave. So we were not getting the x-rays that we were hoping to be able to, gauge his lung health with these colonizations and to see if PEP was holding him like we should. So at 6 months old, we decided to bronch, and mom consented. And it showed copious mucus emanating from the right and the middle lobes, just mucopurulent in appearance. It actually clogged the suction channel on the bronchoscope. Visible plugs. The left side was encouraging. It was clear, minimal thin secretions, and thankfully no dynamic collapse or malacia at the tracheal or either bronchus levels. The culture from that did come back MRSA positive, Pseudomonas positive, few Aspergillus, and Candida tropicalis, and fortunately AFB negative. We repeated the bronch 2 months later, or depending on his birthday, when he was 7 months old, just to kind of reassess. They had instilled Pulmozyme in that right middle lobe too, where we saw the plugging coming from. And so another missed x-ray later, we decided to try to bronch him again and take a look to see if things looked any better. And right away at the tracheal level, there was mucoid secretions emanating from that right bronchus. Still, at this point, mild dynamic collapse, so mild malacia at the right middle lobe, bronchial area, reduced volume compared to the previous bronch, and then the cultures came back positive still for MRSA and AFB negative. So concerning bronch for such a little young guy. We had to admit him again at 11 months old for a pulmonary exacerbation, and we got our x-ray at that point, and it started to show this haziness and this wedge in the right middle lobe area, which was concerning for us. And then 6 months later, he got admitted again, initially for nausea, vomiting, and failure to thrive. But then when we shot our next x-ray, we saw that not only just persistent, but worsening right middle lobe consolidation. So the summary for this little guy's first year and a half of life is that he remains colonized with MRSA at 2 months old, Pseudomonas colonization at 7 months old, with cycled inhaled tubermycin starting at 8 months old. He had been hospitalized 3 times, including the NICU stay, twice for pulmonary exacerbations and pneumonia, bowel obstruction, exploratory lap, constipation, nausea, and vomiting. All of that, the NICU stay was, the NICU admission was at 2 days old. The first pulmonary exacerbation admission was at 10 months old and then at 16 months. They finally completed the OI consult in Atlanta at 15 months old. We were so excited. We finally were able to have a plan, and our pulmonologist, Dr. Mackey, which Dr. Fowler knows, had a direct discussion with the OI physician regarding the safest method of airway clearance, and they did say that the vest would probably be okay for this guy. So we started at lower settings. I didn't start I usually kind of start lower settings for like the first 10 minutes and get them used to it, and then I'll ramp them up to like more medium settings, because I feel like the temptation always at home is to knock it down. So if I can get it at like medium or higher settings, then they feel like they're knocking it down. They're still within recommended settings. So we did start at lower settings with him from a safety standpoint. And during that second hospitalization in December of 22, we thought that would be a great place to start the vest when they were under observation during the admission. And it was trialed and was very successful. He did well with it. We also trialed IPV since we had him, and we had him hostage, and we had the opportunity, and it was also very successful. In fact, IPV was way more successful at bringing up secretions compared to the vest. So our recommendation and our preference was to try to send them home on IPV therapy. Mom was there at the hospital every day. I think there was some, Erin can correct me, I think there was some grandparent support at that point to take care of the other kids at the house. So Mom was able to stay with him during the entire admission, and she actually was very involved with the RT. She worked with them in doing the IPV therapy. So she was being taught and also becoming a little familiar with it, and that's what I really wanted to send him home on. But Mom was just like, there's no way that I can do this for the entire time with all of the things that I have to do at home. So she was very honest. So she requested the vest. Our partnership decisions was to kind of combine therapy. And we placed the prescription for the vest, but we asked her to still maintain mask PEP while he would be shaking on the vest. So he could be getting his neb therapy while he's shaking on the vest, but also getting some of that positive pressure to help stent the airways while the vest is trying to shake and loosen things up. And we asked her to continue at a TID frequency, QID even, like on a weekend or whenever she had a good day, if she could fit it in. You know, normally after getting tuned up, patients will go home back on their regular routine of BID therapy, but we just felt this little guy was too sick for that. Mom was non-responsive. We placed the prescription for vest, but Mom was non-responsive to the vest company for processing of the prescription and processing of insurance. So that delayed the delivery for an additional 4 months. He didn't get it till the following April. Meanwhile, repeat chest x-rays in January and then again in March showed no significant improvement, and that right middle lobe area was significantly problematic, and wording on the radiology report was obliteration of the right heart border. He had a brief one-day admission this past June, due to fever. But so at this point, he had the vest for 2 months, and Mom was using it, and she said it was going really well. In fact, she thought it was great because she could kind of sit him down, let him shake while she was able to do other things with the other kids. During this one-day admission, he was discharged on PO antibiotics, and we scheduled an eye exam and planned to start him on the ETI therapy at his 2-year birthday, which was going to be the following month. And he did get started on that in July. And mom called back and said that she saw excessive productive cough for the first 2 weeks. So that's something that we would normally see in somebody with a little more advanced, or even end-stage lung disease. And then nothing. It just stopped. So the flood came and then it cleared. And he survived a family cold virus that was sweeping through all of the kids like normal. She was reporting that, he was reacting to that very similarly to the other kids, whereas before it was putting him in the hospital. So this past June, at a year and 10 months old, during this brief one-day hospitalization, she had been doing the vest and the mask PEP with hypertonic saline and pulmozyme. We were greatly relieved to see improvement in that right middle lobe after 2 months of vest therapy combined with PEP. And actually, when we return next week is when we're going to get our first x-ray since starting ETI therapy. So that's little SB. Any thoughts? I'd love to hear some ideas.
Is he the only one? That was my first question, is there anybody else?
In the family?
No, in the CF community.
With OI?
Yeah.
Yeah. I don't know. Yes.
Yes. Oh, wow. Okay.
Wow. Okay.
Well, thank goodness he was able to start Trikafta.
Yeah.
That'll be
That's a game changer.
for him for sure. Are you going to test the other siblings?
I'm not sure where we're at with that. Erin, do you know? She's our coordinator.
We did test his, I don't think they're all like, both the same mom and dad, but we did test his full brother.
Okay.
But it was negative.
Okay. Okay. That's relief. Yeah.
Thanks, Dabney. That was great. I think there's a couple things. One is the clinics are so busy and so crazy that, hats off to be able to take the time you needed to puzzle through all of these options, because I think very often it's like, here, do this, and that you give them instructions on one thing, and whether it works or not, who knows? And the other thing is that I think it's a great reminder to reach out to other specialists who work with patients that we've had patients with JRA, and I had a paraplegic patient who had a in utero emboli and was paraplegic, and CF, and so many of these other things. But we have so many. There's the physical therapists who are in the neuro clinics and things like that we can really reach out to, as well as the listservs, and to find out if others of our colleagues have experienced similar things. So thank you very much for those great reminders of how to reach out and collaborate.
Thank you.
Dabney, I let Donna go first this time. So my ultimate question is, did you ever get Dad on board?
I have not seen Dad. I've only I take that back. I saw him very briefly in the NICU once. So my job is I'm 50% in the CF clinic and I'm 50% inpatient, NICU and PICU. So I was actually in PICU one day and the NICU therapist texted me and said, Dad's here. And so I was like, watch my patients. And I went up to the NICU and I saw him as he was leaving. So I've eyeballed him, but I've not talked to him and he's not been to a single clinic visit.
So you guys, as a clinic, haven't made any inroads with him in trying to explain, yes, this is a big deal, and yes, this is a problem. And you mentioned that grandparent support had come along. Did you guys end up having to do like extended teaching with grandparents, or were they more looking after the
I
other
haven't seen
children?
any grandparents. I think one of the gems in this story is the mom. Like she, I think after several rounds of seeing him sick, and he had significant symptoms. Like he would be tachypnic, he had retractions, even wheezy at one point. And I think that was, seeing her son like that was like a great, these people are serious. So she, again, with my open-ended questions, really had all of the right answers. And I really felt I had some confidence that she was doing the treatments and doing them as best that she could at home. And so I think whatever parental support from the dad, I have no idea where the dad is. I think that she's making it work. She's the one that's pulling it together and making it happen at the house.
Well, kudos to her, especially, but kudos to your team for working through this complicated thing.
Yeah, it was kind of fun to sit and brainstorm and hi, Amy.
Real quick before the next question, I would ask you guys to just, if you would, sit tight. We have a patient that's going to be presenting as our last speaker. Her presentation is not very long, but I think you'll enjoy that as well.
Do we have time for one more? Okay, fascinating case. Thank you for sharing. You had mentioned earlier the treatment with Toby and Pseudomonas growth. Can you kind of speak to that at all? Were you able to eradicate Pseudomonas? And have you been able to monitor hearing with your concerns about auditory concerns in OI?
So no, he's still culturing positive for Pseudomonas. He's still on cycled therapy. And interestingly, when I was reviewing this, probably when did we have to upload? Like a month and a half or so ago, I had a rough draft of this presentation, and that slide where I had the different types of OI, I sat down with Dr. Mackey, who's our peds pulmonologist, and I was like, hey, like, go through this presentation with me, help me make sure that I have the timeline correct. And she saw the hearing loss, and she was like, oh, I didn't realize that. She's like, we're definitely going to have to. So that was just a month and a half ago, but I do think that we're going to have something scheduled very soon in the next appointment or two. So it's on our radar more than it was before. Okay, thank you so much.
Thank you, Dabney.
Hey, I'm Valerie Pettit. I'm a patient at the University of Alabama in Birmingham.
Sorry about that.
Hey, I'm Valerie Pettit. I'm a
Okay.
Our last video speaker is Valerie Pettit. She's a 31-year-old patient with cystic fibrosis. She was diagnosed at 8 days old on December 25th, 1991. Merry Christmas, Mom and Dad, is what she put. She's been with her partner, Travis, for 10 years. On November 13th, 2019, she started Trikafta. She received her bachelor's degree in business administration in 2014. And in March of 2021, she started helping care for a family with Alzheimer's and did that up until the birth of her son, Hudson. On July 14th, they have 3 dogs. Her current hobbies include caring for the dog, son, mowing the lawn, and keeping up with the Atlanta Braves. She named her son she's a huge Atlanta Braves fan, and named her son Hudson after the former pitcher, Tim Hudson. And her son also happened to be born on the same day as the pitcher. So we're going to watch her video and we don't know, we will be calling her. If anybody has any questions, we're just going to call her if we have time for any questions. Can we make the video bigger?
Hey, I'm Valerie Pettit. I'm a patient at the University of Alabama in Birmingham. I am 31 years old and I live in Tupelo, Mississippi. So first, I want to talk about my family, my support system. They're all, wonderful. So first, we'll start on the left there. We have my niece, Sophie. She's 13 years old, and she is taller than me. Then we have Travis, who's my partner of 11 years, and then it's me. Then we have Candace, my sister-in-law, married to my brother, who's next, Alan. And then we have my mom, Sue, my dad, Kevin, and then there on the end is my sister, Jennifer. My sister's the oldest, followed by Alan, and then I'm the baby. I am the only one with CF in the family. We did have our first little son, Hudson, July the 14th. That's the next little picture. And then my brother and his wife just had their little boy October the 28th. So he's just a few days old. So first, let's talk about my diagnosis. So I was born December the 17th, 1991. in Clarksville, Mississippi. It did not pass my first stool, so my pediatrician told my parents, that we need to be sent to Le Bonheur in Memphis, Tennessee for further testing. She mentioned the word cystic fibrosis at the time, but that was the first, that my parents had ever heard of it. So they sent me in a ambulance, 1 day old, and we got that diagnosis confirmation on Christmas Eve of that year. So I was diagnosed just a few days old. So throughout my childhood, it was fairly normal. My parents strive to give me a normal, childhood, normal life, just because I had CF, they didn't want things to change. So as far as I can remember, I was a healthy little kid. Now I was admitted into the hospital several times a year. Probably 6 times a year or more. The first 10 years of my life, we went to Le Bonheur in Memphis. After that, we moved hospitals to Children's in Birmingham because there was only 2 doctors at Le Bonheur, and things seemed to be progressing more for my, for cystic fibrosis. So we went to Children's, and the doctor that I saw admitted us that first visit. He said with my weight and my lung functions, we needed to be admitted, get some IV antibiotics, and so we were admitted. Usually I would stay, 10 to 14 days. It was almost like home. The hospital was. My nurses were like family to me. Nurses, therapists, everybody that I came in contact with, I could, every visit I'd be like knowing their name. But now that I'm at UAB, the adult center, I don't really know their names. There's a few that I know, but I don't get to know them as much just because of Trikafta. Because Trikafta keeps me stable and keeps me healthy from needing, IV antibiotics. So I'm very, very thankful for that. All right, so that first picture over there to the left is my niece and I at an Atlanta Braves game in 2014. That game, or that trip, was definitely one for the books. I was on IV antibiotics, and we had stopped through Birmingham to have my labs checked before going to Atlanta because, we needed to make sure the antibiotics were at the right doses and such. So we went through, had my labs checked, went on to Atlanta that night, and we went to that game. Pretty sure the Braves lost because they did lose most games that I attend. Maybe I should just stay home, No. So the next day we went to the Georgia Aquarium, and then after that we went back to the hotel to rest a little. I was more fatigued than normal and had some swelling, but nothing that caused too much of a concern, or so we thought. But the doctor ended up calling us while we were there and said that we need to get back to Birmingham, that I was in kidney failure. So we rushed back to Birmingham. It was me and my mom that went, and then my sister had her car there. So she stayed back with her daughter and Travis. So they came later after they got everything packed. That was a wild time, but thankfully after a 14-day stay and a few rounds of dialysis, I was able to recover fully. And I don't really have any effects to that or from that to this day. So I graduated high school in 2010, After that, I went on to college to Itawamba Community College, and that's in Fulton, Mississippi. I finished there in 2012 with my associate's degree. I went on to Mississippi State and got my bachelor's degree in business. That's also where I met Travis. So very thankful for that time. But also while I was at Mississippi State, I participated in one of the first bigger studies that I've done. That was the Orkambi study, and it definitely came at the right time. You know, trying to figure out life, college life, and being away from home for that first time, and Orkambi helped to keep me stable. It wasn't as good and clean as Trikafta is, but I'm still thankful for that. So moving on, that picture to the right is me and Travis when I got into another research. This was in 2019. I'd been dealing with the loss of my dog of 18 years, and then my brother had moved to Texas for a job, and also one of my best friends that had CF had passed away that year. So it was a pretty tough time. So my mom suggested, you know, that I look into another study to kind of keep my mind busy and maybe look into one that's further off. So I emailed that coordinator, and we set up an appointment for me to come for my first visit in January of 2019. So we made our first trip out there, and we made several more monthly until September of that year. And those were definitely some trips of a lifetime. So November of 2019 is when I received my Trikafta. That's what you see here in this picture is when I received that. So pre-Trikafta, as far as treatments, you know, I would do breathing treatments and vest therapy 3 times a day, and, you know, even 4 times a day sometimes, depending on, you know, my health. And but now post-Trikafta, so if I started in 2019, each year it seems to, in my opinion, get, you know, help more and more, which I don't know, you know, but so now I'm off all of my breathing treatments and all of my chest therapies. I only do those, you know, if I need them or if my lung functions seem to be dropping. I keep up with those with the new at-home spirometer, thanks to COVID. So anyways, the bottom picture is me and Travis with our sweet puppies, Cora and Lucy. They're spoiled rotten. But so after I started Trikafta and we saw some stability in my health, we decided to start talking to the doctor about maybe getting pregnant. So they finally, they okayed it and said, you know, with Trikafta, I should be able to, you know, handle it like any other pregnant woman. So we decided to start trying in May of 2020. We got pregnant that first month trying. That unfortunately led to a miscarriage. So we tried again for another 1.5 years or so. After not having any success, we went back to the doctor, and he suggested we try some IUIs. So we went through 3 rounds of IUIs. None of those were successful. Talking to the doctor more and doing our own little research, you know, we decided that IVF was probably the next best option. So we got a referral over to the fertility clinic in Birmingham. And we got an appointment actually fairly quick. So we got in on November 19th of 2022. November 9th of 2022. So many dates to remember. So we went to UAB, had our first consultation visit. The following day, now keep in mind they didn't do a pregnancy test at that visit. That was just kind of like just to get all the information and all the questions answered. So the following day, I'm feeling off a little. So I decided to take a pregnancy test. Well, lo and behold, we are pregnant. So thankful that we didn't end up having to go through IVF. That would have been a whole lot of stress that I probably didn't need. So,
Unfortunately, I think we're going to have to stop the video. We're going over on time, and I know people have other sessions to go to. Thank you for coming.
I would say if anybody's interested in seeing the rest of her presentation, please just reach out to us and we can forward that presentation to you. We asked her to speak a little bit about her airway clearance, exercise tolerance, and things like that pre and post Trikafta, which I believe she mentioned in her presentation, and what she used to determine whether she should continue or not. So if anybody's interested in seeing the rest of that presentation, please let us know. I apologize that we have to cut it short because I know there's other sessions beginning at 9:30 and there may be another one in this room. So thank you all for your patience and sitting here with us and participating in this session.